Well, good morning all, and welcome to the third in the series of a high-performing primary care series in relation to the RACGP Standards 5th edition in accreditation accordingly. This is part C. This is digging deeper into the quality improvement and general practice modules. Those two other modules, of course, we've done the core module, and now we're moving into the general practice and the quality improvement modules accordingly. Don't forget that please use the chat box if you've got any questions throughout, and we will monitor the chat box as we move through from there. Please utilize the chat box, as I said, and we want you to get the best or the most out of the presentation today accordingly. I'm going to, Meryl has said good morning, and thank you, Meryl, this morning for that. It's great to be back accordingly. So let's start in relation to acknowledgement of country. In Northern Queensland, PHN and AGPAL acknowledges the Aboriginal and Torres Strait Islander peoples as Australia's First Nations peoples and the traditional custodians of the land. We respect their continued connection to land and sea, country, kin and community. We also pay our respect to their elders past, present and emerging as the custodians of knowledge and of law. Well, I don't need to introduce myself. You know who I am. This is because this is the third time we've been through this accordingly. Of course, we spoke the high-performing series. If there's anyone new on board today, this is supported by your PHN through the Australian Government's PHN program accordingly. There are 4 components to the series, and we're, of course, number 2, the standards, the 5th edition from there. And there's 2 other series which we're running out, one on population health and digital literacy, and the last one, which is my favourite, integrated care, but I'm not doing that one, but that's my little pet topic in relation to integrated care. So in relation to this series, there are some framework around what the primary care series is really all about, and we've touched on a couple of these before. But the third one I want to touch on today from this slide is embedding a culture of continuous quality improvement. One of the things we've got to start to think about for the future is any CQI that we do should form part as business as usual, our BAU, our business as usual. CQI should not be that process by which I start today, do something and stop tomorrow. And accreditation is no different. Accreditation is about CQI. It's a continual quality improvement. It's every 3 years. In that 3-year period, there's an action plan which we normally work to as a result of what may be some recommendations placed on your report provided by your provider of accreditation services. Even more so now as a result of PIP-QI as well, continuous quality improvement has got to form part of our DNA, the way in which we do things. So I want you to start to think about it as continuous quality improvement is part of doing business in our practice, rather than the fact of a one-off project that we do every time accreditation comes around, or that PIP-QI report comes back from your PHN accordingly. So when we're looking at the high-performing practices. This is, as I said, this is part C, webinar part C of our of what we've been doing. The series is designed to support you in all these respective points. We've touched on these ones previously, but to me, I keep coming back to the second dot point here. What we're going to talk about is the continued intent of the indicators. And of course, the 3 words we remembered was the could, the musts, the coulds, and the intent. And I think we need to be mindful of let's get the intent right. So when we looked at part B, which was the core module, I'm going to ask you to, if you could, in the chat box, I'm going to ask you one question about core module B. the core module, which we did in the B webinar. One question I've got, and could you put an answer in the chat box for me? And that is prescriptive evidence mandatory in the standards? Is prescriptive, I should say, is prescriptive evidence mandatory in the 5th edition standards? And you just drop an answer into the chat box. That will be great. Thanks, Tanya. You are correct. Janine, yes, you are correct. Prescriptive evidence is important. Thank you very much. You all remember the presentation in webinar B 2 weeks ago. You are right. It is prescriptive is mandatory. And if you're an AGPAL client, which I think most of you may be, or there's a lot of PHNs on board, in Accreditation Pro, when you are uploading Accreditation Pro for prescriptive evidence, you can actually upload that prescriptive evidence accordingly in Pro as an attached document. So when I get it, I can see that the prescriptive evidence is there, and I can assess that before I go on site. One of the prescriptive pieces of evidence which is required, and that is in the infection control policy. Remember, infection control policy is more than just washing hands. As I may have said to you before, I've actually had practices upload a diagram of someone washing their hands. It's more than that. It's a fairly lengthy document covering a whole range of areas. And if you go to the resources in AGPAL, there will be a policy there on infection control. So what are we looking at today? We're going to look at Part C. We're going to look about introduction to the quality improvement module. As part of quality improvement module, we're going to look at 3 QI criteria: one on patient feedback, one on the safety and quality use of medicines, and of course, we're going to look at managing clinical risk. And then we will look at taking a break somewhere in relation to this, and then we'll move into Part C, which is introduction to the general practice module, known as the GP module. And there are at least 2 criteria we're going to have a look at: qualifications, education and training of healthcare practitioners, infection control, including sterilisation, and this is part of prescriptive evidence. And then to finish off, we're going to look at guidance for you in relation to an on-site survey visit in relation to the AGPAL, model accordingly. Now, as you may have heard me beforehand, having discussion with Janine, today is Remembrance Day, the 11th. We will be finishing a little bit earlier today, so which is 12 o'clock my time, 11 o'clock your time, which will allow you to, where applicable, to move into a remembrance service or a minute silence in relation to our fallen accordingly. So that's today's program. Please continue to use the chat line. What I'd like to do on this is that I did a presentation yesterday, about 4 hours yesterday, online for another PHN. It wasn't around the standards, it was around some other topics, emotional intelligence and the foundations of fundamentals of practice management. Well, I tell you what, the questions we couldn't keep up with the amount of questions coming through. So you're going to beat this PHN, and I'll let you know at the end whether you have or not in relation to feedback or just or comments or questions as we move through today. So we've already covered the core module, and we've got 2 other modules now. Remember, the college have restructured their standards, which I think is an excellent way they've done. They've done a module, a plug in and plug out, and in any standards they write, the core module and the quality improvement module remain the same, and then they replace the general practice module with other standards which they may write specifically as well. So it's a really good model accordingly. So let's have a look at the quality improvement module. And I think when we think about the quality improvement module, because quality improvement plays a big part now in our day-to-day life of primary healthcare, this is a very timely module that they've introduced based around quality improvement. Now, in quality improvement, you notice it's headed QI. So any standard indicator will always indicated by the words QI. There are 3 criterions: quality improvement activities, so patient feedback, and improving clinical care. So there's 3 criterion accordingly. So what we want to look at first, we might look at criterion QI 1.2, patient feedback. And these are notes from explanatory notes from the standards. I keep reiterating in every criterion which we use the importance of the explanatory notes, because explanatory notes actually set the framework by which you can look at and say, well, what are we trying to explain? What are we trying to achieve by this criterion? And it also gives you some guidance in relation to what you may need to meet this criterion. Now, the advantage we've got if you're an AGPAL client is that this information is available to you within the hub. And if you hover over the respective criterion with your mouse, what pops up on the screen? It's actually the information from the college standards, the explanatory notes, and ways and means by which you can meet this criterion. So AGPAL they've overlaid the requirements from the college standards into Pro. So why is this criterion is important? Because what we need to think about here is this practice we run. Why are we here? We are here to provide a service to our community, our patients. And that's why we're here. How do we improve our services if we don't get feedback accordingly? There's a number of ways by which we can give feedback, but the college has a specific process in relation to how feedback takes place. And we'll have a discussion about that in a moment. So collecting feedback about patients, about their experience, has shown to improve clinical effectiveness and patient safety. A greater adherence to medications and treatment. And medications are a big challenge in relation to the cost of our healthcare system and the ongoing health and management of our patients. And of course, patient feedback looks about preventive care and screening services. We can use patient feedback to design programs within our practice in relation to preventive healthcare. So the criterion for this particular criterion QI 1.2, there is a requirement to collect feedback. So this is mandatory. We are required to collect feedback, and we need to consider this feedback and make use of it to improve the quality of care that you provide to our patients. There could be other ways of feedback we can encourage as well as the you coulds. Encourage patients and carers to raise concerns directly via the complaints process or an email process or information box in the surgery. By all means, there are varying ways you can do this. So let's have a look at this this criterion accordingly a little bit further. In collecting the feedback, the recommendations are and guidance if you choose to seek feedback from patients on an ongoing basis over a 3-year period. We can. Requirement is that if you choose this method, you ensure that the overall process still meets the requirements of the RACGP feedback, patient feedback guide. This is quite critical. Any sort of tool which you use to collect feedback must be approved by the college. There is a document that the college put out, a guide they put out in relation to patient feedback guide. There is one approved for Aboriginal medical services for the ATSI culture. So the one has been approved for that. So if you're an AMS or you have a high percentage of Indigenous in your practice, there's a specific feedback guide approved by the college on this. No doubt the ones that you've been using, there's a number of them which are being used. I think the majority of practices I see around, I would say about 98%, 99% is the CFEP one accordingly. So you need to utilise a patient requirement. Thanks, Lisa. Have a look at the ATSI one as well. So you need to choose one which is a requirement and signed off by the college accordingly. Yes, you can do your own, but in doing your own, it must be approved by the college accordingly. So we need to be mindful that there is if you wish to do your own, it's a pretty sizable task to actually do that accordingly. In using this feedback, there's a requirement to analyse it and use it to improve quality care. Generally, if you use one of the ones approved by the college, they provide you feedback, they analyse the feedback, and then it's up to you to go through that feedback and say, what's my action plan on this? So we like to see, surveyors like to see your feedback and any sort of action you've taken to address that feedback accordingly. The college standards say a requirement that just you don't have to do it, you have to show what actions may be on this. And there's a requirement to identify key issues and decide on a quality improvement plan, as I just said. The good thing about this is that this can be linked to your PIP-QI quality improvement register if you wish, and this forms part of your overall quality improvement strategy, not necessarily one for accreditation and one for PIP-QI. They can be the same. They can be the same document accordingly. One of the things that I do at my practice and practices do is that they actually display a sign and say, thanks very much for your feedback, and this is what we're going to do. And let's put up on the sign, a sign on the waiting room wall, or in their practice information sheet, or on their website accordingly. So this particular criterion makes sure that you carry out the feedback in the prescribed manner, and then have an action plan in relation to what you may need to do in regards to any sort of quality improvement action which take place. Just as an aside, there is a, and I know with one particular company, if the doctors want to pay an extra $80, I think it is, and all my doctors did, they just complete an action plan, a feedback plan as a result of their specific, so when we signed up, each doctor signed up in our practice, and the forms which were handed out were identified which doctor it was, and the doctor receives their individual feedback, and all the doctors in the practice then become aggregated into a practice one. Then each doctor then goes through and does an action plan for themselves, and for that, they then receive 40 category 1 points for their CPD QI process. So with one particular organisation, I can't talk for others, which is CFEP, they offer that particular service, but there's an $80 cost per doctor for that, and that's how they can gain their extra category 1 points. And in this day and age, I think doctors will be looking for their category 1 points as a result of COVID and what education and training they may be doing. But it's got to be on a prescribed, process for that. So QI 1.2, you notice the sign, the little arrow to the right, and that says mandatory. A says our practice collects feedback from patients, carers, and other relevant parties in accordance with the RACGP patient feedback. Now, some guidance. This is the circle, yellow circle with an eye in the middle. Whenever you see this, this gives you an indication of what you need to think about. The trick to patient feedback is that get the feedback started early. And what I find is that they're often left late, and by the time the accreditation takes place, the results aren't back. So what do I have to do is mark you not met to QI 1.2. because the results haven't come back and you haven't done any quality improvement action plan. It's okay to conduct the survey mid-cycle, as current as that, but just get it done earlier. There's no requirement that says it's got to be done 1 month out or 2 months out from your accreditation date cycle. So, where sort of educate patients that the mid-cycle would be a good time to do it. Now, depending upon the number of doctors you have in your practice will depend upon the number of surveys that you need to carry out. And the college makes that determination in relation to your patient flow. In my practice, because of the number of doctors I have, I think we have to do around 300, I think, patient surveys accordingly. There is an online version if by one of the organisations. I can't comment on the others, but one of the organisations that provide there is an online version, and some practices are utilising that via iPads in the waiting area accordingly. So some of the providers may have moved into online now. So have a look at that accordingly. But you've got 3 years to conduct a survey visit. Don't hold off to the last minute, because it could catch you out accordingly. So has anyone got any comments in relation to the patient feedback? If you have, just drop it in the chat room box, and I'll answer those as we move through on this. The next criterion in the quality improvement standard is QI. We've just done QI 1.2 patient feedback, and what we're going to move into now is the standards. And as I said, there are 3. One from there are 3 standards, and now we're going to. So we've just done quality improvement. We're now going to look at QI 2.2, safety and quality of medicines accordingly. Now, in relation to safety and quality of medicines, each state has their own legislation in relation to how S4s and S8s are managed. Of course, we are now talking on, you're from Queensland, and Queensland has different legislation based around the storage of S4s and S8s, and you need to be aware what that may be. Your surveyors from Queensland will be aware of the current legislation accordingly. So what are the key points from explanatory notes in relation to safe and quality of use of medicines? We all know that research has shown that, the numbers I can't give you, but they're very, very high of admissions to hospital in relation to the wrong use of medicines. And in the 5th edition, there's been some changes in relation to patient awareness from our practice in regards to use of quality of medicine. It's just not about the storage of S8s. It is now the storage of medicines and the information we may need to provide the patient in relation to medicine usage. And we'll talk about that in a moment regarding health records, etc. As the explanatory notes say, if a patient understands the reason for the medication they believe, then there'll be a greater use in relation to the benefits and risks of medication, and they can make an informed decision around this. And when they make an informed decision, the treatment, and they'll be more likely to follow the treatment plan that a medical practitioner has put into place accordingly. It's interesting around this. I know I might have told you the story, I may not have, but we had due to patient notification, which I know I did in the core module, about that patient story about the wrong patient was put in the file of a morning in the appointment book. But thank goodness for the patient who was aware of what her status was in relation to allergy, although the doctor used the wrong file. She had the sense to actually, her health literacy was pretty strong. Automatically, she looked at the box when she got home and realised it was penicillin, and she had an allergy to penicillin. So health literacy plays a big part in this accordingly. The part of this as well is, as the college says, it's about the importance of antimicrobial stewardship and being a part of maintaining antibiotics. The challenge we've got on antibiotics, we're moving into our antibiotic of last resort, the world storage of antibiotics. So we're heading for, I believe, I understand, for resistance going to build up the antibiotics. We'll have no antibiotics of last resort left. So we've got to start to think about usage of antibiotics accordingly. And then, of course, We're going to talk about in the explanatory notes, support patient health and safety by informing patients about medicines. Sample medications is an introduction, as you'll see, what we may need to do with sample medications now, and medical consumables. And also, we need to look at expiry dates from all that. So let's have a quick look in relation to the criterion 2.2, safe and quality use of medicines. In relation to this, is that part of this is just an overview of what government's thinking in relation to what we need to do in our practices, our clinicians need to do as well, and for effective use of medicine. So when we're talking about this particular criterion, there is a background that sits behind this. We need to start to think about what the criterion is, the explanatory notes, and how does that translate across into what we need to do to meet this particular criterion. So this is just not about, as I said, storage of S8s accordingly. This is about making our patient wiser in relation to the use of medicines, how they're taken, when they are taken, the reasons for. So there's an education component now of this criterion, which we'll see in a moment. We have to move into some form of education process. We also have to move into thinking around documentation, greater documentation in relation to medicine usage in our practice. And then we also need to think about in this criterion around the storage and use of sample medication that we have within the practice. But you notice the bottom left-hand side of the screen, with a big red circle with exclamation mark. What are the legislated requirements related to the acquisition, use, storage, and disposal of Schedule 4 and Schedule 8? That particular red circle exclamation mark is really the basis by which a policy can be put together in your practice around how you acquire, how you use, how you store, and dispose of Schedule 4 and Schedule 8. You need to look at your state respective legislation on this, which varies from other states as well. Western Australian varies again, but you need to look at what your states may be. If you speak to your CLO at AGPAL, they can provide you a document accordingly of what your state requirements may be in relation to the legislative requirements of this. So what does this look like, this indicator? What do we need to do on this? Well, indicator QI 2.2 mandatory E says our clinical team. Now, remember we spoke back in the core module or back at the introduction around the change of thinking by the college in relation to the standards. We're now talking about the team is just not the doctor. So the clinical team, our nursing staff or other clinical people in the practice, they ensure that the medicines, the samples and consumables are acquired, stored, administered, supplied and disposed of in accordance with the manufacturer's directions and relevant laws. Now, this is a pretty big indicator for you, and my advice to you on this is that some practices put a policy together on this, and there's one policy which covers QI 2.2. As I say in the guidance down there, the legal requirements for medicines management will vary from state to state. This is that it's not only AGPAL surveyors will pick this up, but also you need to be prepared that your state Department of Health or pharmaceutical branch will carry out audits in relation to this. New South Wales have carried out audits, pharmaceutical branch have carried out audits in New South Wales the last couple of years. Accordingly, the provision of documentation. Now, you notice the last two words in this particular indicator, in guidance, to the medicine labels. That was 4 words, wasn't it? Now we need to think about requirements according to medicine labels. Samples, S8, S4s, S2s, do they have directions on them? Do they have the ability to write on the back of when these are being given away free of charge? we need to think about samples in this particular indicator now. Do you keep samples or don't you keep samples, medical samples? If you don't, that's great. That should form part of your policy. If you do, and they are given away to patients, there's a requirement now as far as the respective provider of the samples, that certain information now must be provided by the patient on the pack. Like date of birth, name, date of birth, and prescribing, how they are to take them. Just like any other prescription that the doctor provides now, that information has to be on the pack of sample packs. Now, some samples, sample packs now have that information automatically on it. The pharmaceutical companies have done that, but others not, and a lot of practices actually do labels and stick them on the back. Now, in AGPAL's hub, there is a template in there that you can print labels off to stick on the back of sample medication accordingly from there. Now, there's also a requirement that when the sample medications are issued, there requires to be a note in the patient's file as well. So what's the difference between a sample, that's what the college says, what's the difference between giving a sample pack away, and prescribing something via the normal prescribing process? There's no difference. So any samples given away, you have to have on the back the information regarding how they are, the patient's name, identifying who they're given to, and also the instructions of taking them, and that needs to be recorded in the patient's file. Has anyone got any questions around that? Has anyone got any comments around that? Are you doing that now or not doing that now? It'd be good to hear from you all, anyone from there, whether you've been confronted with that either from the your local Department of Health or from you've actually moved into that 5th edition requirement for samples accordingly. This is a big one for us as surveyors. We will now assess those. We'll look at your sample cabinets. We'll look at the sample medications to see whether that information is on the back. If not, it'll be a challenge to actually meet that particular indicator. And then what the practitioner surveyor will be looking at is looking at the patient's record to see whether that sample, which has been provided, is recorded in the patient's file or not. There's no one in the chat room on that, so I'm assuming that at this particular point, no one's had any experience with that. Is anyone doing that now? Is anyone writing the information back on sample packs and putting the information in the patient's file? It's an area of compliance which is not overly high, but we're finding with practices now, a lot of them do not keep sample medications accordingly from there. Righto then, that's criterion QI 2.2 from there. So let's have a look now at, so that's the quality improvement standards. We just finished standard QI 1.2. We'll now move on to, so we've just done that. Now we'll look at standard 3 now, and in standard 3, we actually have 2 criterion, and the first one is managing clinical risk, and the second one is what we call open disclosure. And some of you may be aware of open disclosure and what does that mean, but that's a new concept in the 5th edition. A lot of people struggle with this, not knowing what it all means. And of course, managing clinical risk in this QI improvement has been upgraded as well, and there's more things that we need to do on this. Let's have a look at managing clinical risk. Explanatory notes are important in relation to this particular indicator. Once again, why is it important? Because if you look at patient safety incidents in clinical care occur in all health settings. Part of this particular criteria is about adverse events and near misses. And you would, in the 4th edition, be aware of adverse events and near misses. And part of this criterion bases itself around adverse events and near misses and what we may need to do this. Also, the managing in this criterion is that there are certain consequences to our practice and to our patients in relation to not making improvements after we identify an incident which takes place. And we'll talk about in a moment how you will comply with this particular criterion with the respective indicators. I think some of us do this quite now. You know, we fill out an incident form and there's an action process. How do we investigate? There's an action process which may flow from that. This is around clinical risk. And the third dot point is that why this criterion is important is about it's the value of actually having a system. So so a system is important. What is your reporting system in this? Now, to meet this criterion, we already have, as I said, a risk. We all manage risk on a daily basis now. It may be through an informal process or an ad hoc process and aimed at preventing near misses and adverse events. I have a process in place that I need to know within 2 hours by staff. That's my SLA, my service level agreement, that there has been an incident accordingly, or a complaint. Don't forget that complaints also are a clinical risk. This is not a needle stick injury or the wrong immunisation given. This is also about a complaint which has been made about someone or something within the practice. There's no, don't think this is about, it could be someone who, a nursing staff who was, made a child cry or whatever it may be accordingly. So this is just not around doctors prescribing. And in my practice, I've got a 2-hour SLA where staff need to send me an email no matter where I am in the world. And within 2 hours, I'll get an email saying there's been a complaint or etc. And then they have 24 hours to, depending upon the severity, to submit a clinical incident report to me to take it from there. What does that do for me? Within that 2-hour period, I'm back to the person who made the complaint or made the feedback. And then in turn, I have the discussion saying, thank you very, very much for this. Just touching base on we've got your concerns raised and your feedback. I'll be investigating this and in turn, I'll get back to you once I find out the process, and I'll have a discussion with you around this. And we'll come back to you then after that with an action accordingly. I'm not solving the incident right up front. I'm just making contact. A medical defence organisation from South Australia back in the 90s said that 96.8% of their complaints would never have gone to court if there'd been effective communication in the first instance. So I can't stress enough, and I can see where the college is coming from in relation to managing clinical risk, is that what is your system to be able to manage this? So when we're looking at meeting this particular criteria, we need to think about what are your recommendations around how you reduce near misses and adverse offence. This is also about being proactive rather than reactive. Reactive is good because you then put into place to reassess policy and procedures, or at the same time set in place to review current policies and procedures, or bring everyone up to start. Part of the reasons this explanatory note is that when there is an incident in the practice, it gives us as a manager and time to let everyone know of the outcome of this, so it refreshes their memories on what may be as a result of the learnings accordingly. We need to start to think about then in meeting this criteria, what does this need to look like? So in managing clinical risk, the indicator says, once again, you notice QI, managed from the Quality Improvement Standard 3, Criterion 1, mandatory, indicator A. Our practice monitors, identifies and reports near misses and adverse events in clinical care. You notice this indicator, there are 3 areas you need to address. You need to have a policy in place or a process in place that monitors. Well, the first one I would put the other way around: identify, reports, and monitors near misses and adverse events in clinical care. Just having a reporting form does not cut the mustard on this particular indicator. You need to show the surveyor that how do you identify, how do you report, how do you monitor accordingly. So this is always very good to have a register accordingly. Yes, the reporting mechanism is one part of the requirement of this indicator. And the report is the report. But then again, how then do you identify any risks in the practice first? So this is about being reactive and proactive. Proactive comes first, about identifying. Reactive is the report and then the monitoring processes. So think about this one a little bit more than what we have thought about before. This is about creating a culture within your organisation, a no-blame culture within your organisation, because we have to create a no-blame culture. Let the staff put their hand up and say, look, I think I gave the wrong injection to that child accordingly. Or, look, the child moved their arm as I was giving them the immunisation, and I've got a needle stick injury from it. There are other things that in clinical care that may have taken place. The penicillin one was a good one to the extent that that's an adverse event. The other one, of course, we need to think about is the wrong letter scanned to the wrong patient's file. That is an adverse event in clinical care. So just don't think about the fact of the wrong injection or the needle stick injury. Think about the administration side of it as well. I might have told you recently we had one where, due to a wrong email address, just by the insertion of a middle letter, clinical notes were sent to a patient that ended up with someone in the US that had this similar email address as the patient, but the only difference was the letter L between the two names. And when it was transposed into our medical records, the staff didn't pick up the L. And I looked at the new patient form, and it was very hard to pick the L. So that is actually, that's a near miss. So what was the report came in as a result of that? What was the outcomes of that? We then introduced encryption of emails with sensitive clinical information in the practice. So there is a learning. So that went into our quality improvement register under clinical incidents with an outcome. And that's what I would show. So think about that wrong letter to the wrong file. It might happen quite often. So how do you then manage that within the practice? Document it accordingly. Your quality improvement register or your risk register, which we spoke about in the core module, you may want to identify risks around near misses and adverse events. You may want to identify what these risks may be and put into place a strategy in relation to how you're going to manage these risks. So all of a sudden now you've got your risk register where you identify risks and how you'll monitor risks. And then you have a process in place where there's a reporting mechanism in and actions as a result of that. This really is about documentation, dare I say it, in this particular indicator. No doubt we are doing it now. We are doing this sort of stuff. Do we have a policy about it? And do we have any tools, evidence to show? Now, remember evidence on this. It's up to you to provide evidence to validate this, but it's not for the standards to say, as we've said before. The burden of proof now is upon the practice, not upon the surveyor. So whatever example you want to put up in your system, that's up to you on this. And surveyors are quite flexible in relation to what they will accept on this. And there could be some CQI, continual quality improvement, which comes out of this. Once again, in managing clinical risk, This is B, indicator B. Our practice team makes improvements to our clinical risk systems in order to prevent near misses and adverse events in clinical care. So this links into the previous one, which was A. So what is your process in relation to making improvements to your risk management systems? And once again, this could be that register which we spoke about. And like I can show, for instance, I'll just give you an example today. That encryption of emails via Adobe we put into place last week or the week before, and it's working exceptionally well. And what is the password to open that attachment is the date of birth of the patient. Well, today, and that's all in my register, improvement register, but today my chronic disease management nurse said, "Oh, Gary, I send stuff to like HMR requests to my community pharmacist, but when I send it, she doesn't know the patient's date of birth." Interesting. So I then sat down and said, this morning we worked through how we deal with this when the recipient does not know the date of birth of the patient, because that's the code we use. The other side uses to unlock it. So if I'm referring to a specialist and the patient hasn't been there before, they can't open the document. So I then send a second email to those people and say the password is the postcode of Penrith, for instance. So that revisiting, like a PDSA, isn't it? That in revisiting the system, we found a gap in the system. So now setting up that second email process with a postcode of Penrith for someone who does not know the name of the patient is an improvement, and I'll capture that in this particular indicator. Or if not, I'll explain it. There is nothing to stop you explaining things to the surveyor. Now, the surveyor will make the determination to say, well, should that be documented or not? If it should be documented, well, it may be a CQI that fits into that. So you might want to explain the situation just like I did to you. So this particular indicator is all about making improvements, and what do you do to make improvements accordingly. Righto. We've looked at criterion now. Standard 3, standard 3, and criterion 1, managing of clinical risk in the QI space accordingly. So there it is. We've now done the quality improvement. We've done the quality improvement module now, 1, 2, and 3 from there. So before we move on, are there any questions accordingly? Has anyone got anything in the chat box in relation to the quality improvement module? Because we're going to take a break in a moment after this, because we'll then move to the general practice, because we might take a 15-minute break. This webinar is slightly shorter because the QI module and the general practice module are a little bit shorter in relation to what we've got. So has anyone got any questions in relation to the QI, or comments in relation to the QI quality improvement module? Because it has changed, as I said, there are more things in there, things that we were doing before having been expanded. Lots of them have been expanded now. So the 5th edition is a little bit more involved than the 4th edition accordingly. Lisa, thanks very much for your comment. You seem to be across some of the requirements of the QR module. I appreciate that. From there, has anyone else got any comments they want to make about the QI module? Do you find them challenging? Have you met them now, do you think? Are you going to struggle to meet them accordingly? Just give me some feedback and I can provide it back to others as well. I think the most important bit in relation to the QI module, as it has expanded now, there are a number of parts to each of the indicators, where before there used to be one thing you have to do, three things you have to do within the indicator for the quality improvement. Although there are only 3 standards, they're fairly in-depth standards accordingly. Once again, I can't stress enough, if you go to the hub, AGPAL hub, and a lot of those policy and procedures templates are there, and you can use those accordingly. And thanks very much for that last email that went up in the chat box. I think it was put up by Lisa. Lisa, do you want to come off mute for me and give us a rundown on that particular email which you put up there? You there, Lisa? Lisa doesn't seem to be there from there. So there was a document, a link put up over the break in relation to the changes between the 4th and the 5th edition as well. That was available on the AGPAL registry resources as well. From that, it's a pretty good document to map across the differences between the 4th and the 5th editions accordingly. And I must admit, as I said to you previously, and I'll talk about it towards the end, that particular document had indicated that, oh, so that's okay, Lisa, you can't unmute yourself. Thank you, that's fine. That particular document is a document which I used, although I'm a surveyor and I've got a pretty good understanding of the college standards or the intent of them. I just use that document to say, well, that's what it was before, that's what I need to do now. And that particular mapping document will assist you accordingly. So thank you very much for that, Lisa, by putting that particular document up there. Right, so then, so we've covered the core module, we've covered the quality improvement module. The next module we're going to cover now is the general practice general practice module on this. So in the general practice module, we have 6 standards: access to care, comprehensive care, qualifications of our clinical team, which we're going to talk about, reducing the risk of infection. We're going to talk about the medical practice, and we're going to touch on that, and then vaccine potency, which I don't think we'll cover because we're pretty well across that accordingly. So the first one we're going to talk about is qualifications in relation to education and training requirements on this, which is general practice module, standard 3. And we're going to look at qualifications of our clinical team. Qualifications of our clinical team, GP 3.1, is an interesting one on this one. We are now looking at the clinical team now, not necessarily the individuals in checking documentation. Before we check documentation specifically around doctors, now we're going to look at all APRA people who are registered by APRA and also by non-APRA people. So there's a new process which we'll talk about in a moment, what we need to put together for the accreditation. But in the explanatory notes, why is education, training and qualifications important? Because it's all about the fact of being able to deliver. Suitably qualified people can deliver the healthcare which is required accordingly. Now, I suppose that in meeting this criteria, there is registration and this new word called credentialing, and we know what CPD is. So when we meet this criteria, we're going to start to think about national registrations, having the proof of their credentialing and complying with ongoing CPD requirements. And as a surveyor, each one of the health team, clinical team you have in your practice will have different requirements for submission to for assessment purposes. And I'll go through your doctors, your allied health, if you have any, and we'll talk a bit about that in a moment. Allied health part of your clinical team, and then nursing staff, and then reception staff. So registration, credentialing, CPD is important, and CPD and other relevant training for other healthcare professionals is required as well by the colleges or by APRA, and we'll talk a little bit more about how does this look. When you're looking at this, we need to understand in expert notes that general practice is a specialist discipline in itself. To be doctors in general practice, as it says, need to be appropriately trained and qualified in the discipline of general practice, and they must be vocationally registered or have a fellowship, if RACGP, or meet the RACGP definition of a GP as registered medical practitioner. So that's so there's a requirement for the standards in relation to GPs and how they are identified as a GP. If it's a requirement of a practice to support registrars and doctors on a pathway to fellowship through the support, mentoring and supervision of a recognised GP. So if you have a registrar there, although they haven't got their fellowship, they still meet the definition. Doctors in rural remote Australia under programs, and they're being mentored and supervision, and they've got respective Medicare components. They will be accepted as a definition of a general practitioner. Where vocationally recognised GPs and doctors on a pathway to fellowship are unavailable. Now, what do we need to do to meet this component in relation to criteria? Let's look at CPR. There's a requirement that all healthcare practitioners, and notice the word healthcare practitioners, must be trained in CPR so they can help in an emergency. There's a requirement that CPR training is conducted by an accrediting training provider or by a qualified clinical team member. Now, CPR is required for everyone within the practice. Your doctors will require this for their meeting their triennium for QI-CPD. Receptionists and/or nursing staff are required to have CPR training over a 3-year period. And although nurse immunisers are required to have annual, but for accreditation purposes, every 3 years is fine accordingly. Now, as we said before, requirement CPR is conducted by an accredited training provider or by a qualified clinical team member. Now, what's the definition of a clinical team member? They must have a current CPR instructor certificate that complies to the requirements of ARC guidelines. Now, we find in rural remote Australia, where it's very hard to get an accredited training provider to do CPR for your staff, some very large AMSs that may have 5 or 6 services, like in far north Queensland and in Northern Territory, they have someone on staff who actually has an instructor certificate accordingly. And generally it's a nurse, and they then provide the education and training accordingly. So CPR training. Now, the definition of a clinical team. There is a document available that from the college that identifies who is part of a clinical team. And one of the areas that takes place for definition is allied health on site, psychologists, specialists who may be coming in, podiatrists. These could be sessional people or people who form part of maybe as employees. Now, the college actually has a guidance sheet on this. If you have these external people who come into your practice for determination if they are defined as part of the clinical team or not. This document is available, I think, accordingly in Practice Hub, but speak to your CLO at AGPAL and I'll provide you a copy of this. But the college has a document on their website as well. I'll give you an example. First thing I do as a surveyor, it must go on your practice profile if you think they are. How do we determine? Well, we look at the website. If they're on the website, you're promoting them. That's the first indicator. The second indicator is that do you take appointments for them and do you collect money for them? Is it on your practice information sheet? But the big one, of course, here is do they contribute to the notes of your software? All these things are tick boxes, yes, no, from an assessing point of view to determine whether they are a part of the clinical team as determined by the college set of guidelines. So if they are, in your analysis, you have to ensure that they have their CPR, they provide a copy of their registration through APRA, and that they provide some form of education and training guidelines that they may be doing. It could be CPD for their own professional development by their association, or certificates to show that they are part of the ongoing education and training. This is one of the biggest changes to the 5th edition in relation to the definition of a clinical team. So you've got to do the assessment in accordance with the requirements of the college mapping guidelines, or I have to do it as a surveyor to ascertain on the day whether they are or not. If you determine they are, they have to go on the practice profile in the Accreditation Pro. If they're not, in your determination, and the surveyor believes they are, we actually have to put them on. And if you don't have that documentation, that will be a non-compliance to this particular indicator, which we're going to talk about. So this is a big decision that you have to make to determine whether they are a member of the team or not. So let's go back one slide. If they are a member of the team, which a GP will be, you are required to provide APRA registration, CPD, CPR. If they're a nurse, they are to provide APRA registration, CPR, ongoing education and training. If they are receptionists, all that I need to see is CPR and any documentation about ongoing education and training. But those 3 categories, and if they allied health, they're required professional APRA registration, if they are APRA, CPD, CPR, and for every one of those criteria, immunisation. So even your allied health, who've been determined as part of your clinical team, require immunisation status known as well. So if I go into a practice, before I go, I pull out a little separate sheet that I've got. And some practices upload this document beforehand, which is great, these documents beforehand, so I can see them. Otherwise, I've got to go through and do this matrix on site. And the biggest part of my time on site as a surveyor is the matrix of everyone who's defined as the clinical team. This is a big part for you. Firstly, determine who's part of the clinical team. This is a new indicator, GP 3.1 mandatory indicator C. Our clinical team is trained to use the practices equipment that they need to properly perform their role. This particular one here, I think it's important to think about this. How do you do this? How do I do this? Well, you've got to show the surveyor that there is key clinical equipment like the ECG, the ear syringing, the spirometry, the cryotherapy, the ABI machine. What is key clinical equipment accordingly? Now, the clinical team includes your doctors, includes possibly your allied health, includes your nursing staff, and maybe your reception staff that actually do ECGs and spirometries, and they can. If you've got a medical practice assistant, they can do that. So I've just done up a document for each of the key clinical equipments in my practice, and my supervisory nurse has gone through and shown all my doctors and all my nursing staff how to use the equipment, and they've all signed off to say that they've done it. And that document will then be produced to the surveyor which meets this particular indicator. This is interesting, isn't it? This once again is all about documentation. Not all doctors know how to use an ECG machine. In my practice, I have nurses on from 7 a.m. to 6 p.m. every day, which we're open. They'll struggle to do an ECG because of the computer system which we use, the software that imports it accordingly. So we need to start to think about this particular indicator accordingly, that clinical staff are trained in the use of. Now, there's a couple of chat questions come through. Meryl said, if RNs provide CPD, I do not believe it's my responsibility to ensure that they have the hours required. No, exactly right. It is not, Meryl. There is no prescription. The standards are not prescriptive in relation to the hours that someone does. It says that there, and I'll loosely translate, Meryl, is that staff have education and training relevant to their role. So there you are, relevant to their role. They can do 1 or 2 hours or 1 or 2 courses, or they can do, my nurses, my gosh, you know, so far this year, I've got one manila folder full of my nursing staff education and training certificates. But some of my reception staff have only done 1 or 2 online. So there's no requirement around hours or amount. It is about education and training respective to their role. In relation to self-assessment resource for practice, we intend to undertake their initial accreditation. If you look at the thanks, Lisa. If you look at on the chat box to your previous, there is a link there to that particular document you raised. Michelle raised a question: does training on equipment document need to be updated? I done every 3 or so years. There's nothing prescriptive in the standards, Michelle, but if you get a new doctor on board, you would then update those accordingly. A new piece of equipment, you then go through and do it again. It doesn't have to be on every 3 years. As I said, it's not prescriptive. But new doctors, new equipment, the answer is yes. Righto, let's move on from that. So there is General Practice Standard 3. 3.1, Qualifications, Education and Training. And we've done qualifications in our clinical team. Remember the definition of our clinical team, please. If you make determination who's part of the clinical team, get that document from the college, or it's in the hub, AGPAL hub, available by log on, or if you contact your CLO, they can provide that for you. But all the definitions are there, all the indicators are there, whether they will or whether they won't accordingly. So there we've done 3 accordingly, 1, 2 and 3, the general practice module. We will now look at General Practice Standard 4, which is around infection control, or really it's about, about reducing the risk of infection in our practice. The purpose of this particular standard is around reducing risk of infections in our practice accordingly. So let's have a look at what may be some of the key points in explanatory notes. It's really about reducing the risk of infection in the practice. Why is important, and these once again is in your explanatory notes. Part of this is around good governance of infection control, including sterilisation, and we'll come to that in a moment. We should have systems in place that are clear, that there's accountability and responsibility by all parts, everyone within the practice. And in doing that, good governance allows then delivery of good quality and safety of care to our patients. Now, in meeting this criteria, there are certain things in meeting this criteria that we need to start to be mindful of. We've got to have, one of the requirements is we have to have at least one member of the clinical team responsible for prevention and control of infection processes. We can do that by identifying that particular person in a position description statement. There's another requirement for this particular indicator that the requirement, so the document who is responsible and demonstrate how the practice team understands and complies. Now, as you can see, we're talking about a policy and procedures in here. So there's got to be a document that everyone has an understanding of how infection prevention and control, how everyone complies to this. So when we're looking at this sterilizer, there is at this component. Part of it, the big part of it is in relation to sterilisation. And currently, I'm finding now such a high percentage of practices do not do on-site sterilisation. It seems to be a thing of the past. I reckon out of 10 practices I go to, maybe 2 have an on-site steriliser, where we go back up until 10 years ago, nearly every practice had a steriliser on board. So, but just because you don't have a steriliser, that doesn't mean that in this particular, you are exempt from this criterion, because it's actually about infection prevention and control. It's just not about sterilising. So there requires to be a policy, which I'll go through in a moment, a policy around infection control in your practice. And we've already have, it's a prescriptive policy, prescriptive bit of evidence accordingly. So when we're looking in relation to sterilisation, there is no requirement by the college have made a determination on this. There is no requirement for numbers on disposable equipment to be logged back against the patient's file. So you don't have to record that batch number or that number on disposables back against the patient's file. It only talks about, for the college standards, about reusing equipment. So reusing equipment, steriliser. Once again, if you use a steriliser, there are certain requirements around this for documentation. Every 12 months, you require your steriliser to be validated and calibrated. And these documents require to be available for accreditation purposes. Also with validation and calibration, this is also about chamber, hot and cold spots, heat distribution as well. Of course, the other component of sterilisation is the documentation of cleaning, disinfection, packaging, and usage. So that the requirements around that still apply accordingly. So there is the college has a standard around infection control of office-based standards. I think that's available also in the hub. So any changes to the infection control or your sterilisation process, you need to ensure that your policies are changed accordingly to reflect it. If you're using a policy from another source, please read my lips. Please customise it to suit your practice, because part of my assessment is I ask questions and I look at documents. And if documents don't reflect the process that you tell me, I notice that there are gaps there somewhere from there. So part of your prescriptive evidence on this is infection control. Now, non-mandatory indicator, you notice there's no blocked arrow to the right on this. Infection prevention and control, including sterilisation. GP 4.1. Our practice records the sterilisation load numbers from the sterile barrier system into the patient's health record when sterile items have been used, and record patient's name against those loads numbers in a sterilisation log or list. This is a new indicator, an updated, expanded indicator, meaning that you now have to put the load number of that pack back into the patient's file. And you then still must keep a separate register, which you possibly do now, identifying the patient's name and batch number accordingly. So GP 4.1 now, indicator F, turns around and says, I now have to put that load number back into the patient's record. As I said in relation to the previous slide, you do not have to put the batch number of disposable packs back into the patient's file. It is only if you use a sterilizer or where you use reissue reusing equipment. In relation to off-site storage, off-site usage, I'll go back to this here. There we require evidence that you use an accredited off-site sterilisation facility accordingly. And I know in a lot of places that they outsource this to the local CCS the sterilisation unit at the local hospital. So once again, we need to see their accreditation certificate accordingly, and you have in place a process by you send dirty and receive clean, and they've got to be, as we spoke about before, in puncture-proof containers, and there's a process of booking out and booking in, but that's part of your policy accordingly. Just as a side, does anyone come online and tell me whether you use an off-site facility or not? And do you want to tell me whether you use a sterilizer or not? So I think this will be important. This will be interesting for me to get an understanding of what happens in far north Queensland around the sterilisation component accordingly. So just drop that in the chat box if you can from there. Let's look at remember that one there is a non-mandatory indicator. So let's now look at, thanks very much for your feedback coming in. The majority of them seem to have your own sterilizer, and some of you actually are recording the batch numbers in the patient's file for your excision packs. Just remembering that there's no requirement to document back in the patient file if they come out of disposable pack. You may want to do it for as a risk management strategy, as what possibly Michelle's practice is doing. They are recording those batch numbers back for I'm assuming for risk management purposes, but there's no requirement under the standards for that. Thanks very much for that feedback. Standard 4 now, we've looked at infection prevention and control, and we've looked at reducing the risk of infection. Now, there is the general practice module, which we are going to, which we've covered today. Accordingly, we've done GPT-3, we've done GPT-4 accordingly, and that completes the general practice module accordingly. Now, I just want to move into so that completes the modules accordingly. What I'd like to do now is to move into some overarching comments in relation to what we've covered off accordingly. Just remember that particular sign, and you'll get copies of this PowerPoint presentation, I'm assuming accordingly. That particular sign says any criterion or indicator which requires evidence from multiple staff members can be not met tipping point. This is where the biggest non-conformant is required. I'm finding now is that there requires to be multiple bits of evidence for these areas in the practice: CPR, CPD, immunisations and registrations. So make sure that you've got the requirements of documentation for all your doctors, CPR, CPD, immunisation registrations. Make sure you've got all those as well for your nursing staff. Make sure you've got all those as well for any other parts of the clinical team like allied health, and for reception staff, CPR and immunisations accordingly. Now, and any sort of documentation to say that any training has been provided relevant to their role. This is a big area of non-compliance that a surveyor will deal with, because there can be, you come to my practice where I've got 12 doctors here. So just multiply this paperwork or validation of, so I've got 12 doctors, I've got 7 nurses, and I've got 5 receptionists, an office manager, and myself. So it's just a massive amount of documentation which is required. Luckily, I don't have any allied health on the practice, so I have no components around allied health as defined as clinical team. Guidance in relation to infection control and prevention and control, and GP 6.1 maintaining vaccine patients. These, as it says, this criterion contains 4 indicators which require a lot of evidence to meet. It is our experience that practices can miss an element, and this mistake can result in 4 indicators being rated as unmet. Because indicators are linked, if you miss one bit of evidence, there could be a series of indicators that you cannot meet accordingly at the time of the accreditation. So once again, these 2 criterion, GP 4.1, GP 6.1, there are quite a bit of evidence which is required. So make sure you've actually gone through and ticked off what evidence you actually need. So here we have, as I said, there is a series of standards which we have covered off on: the core module, quality improvement module, and the general practice module. And that's the standards accordingly. Has anyone got any questions before we move on to some guidance around the on-site accreditation process from AGPAL? So questions on? So let's have a look at this. What I'd like to do now is provide you sort of an overview on how AGPAL processes work. So this process is available on the hub accordingly, and so I'm not showing you anything different from there. So let's have a look at this. There are some recommended processes in preparing for surveys. Pre-organised interviews. What will happen is that in our initial discussion with you, we will have the discussion around timelines of a visit on the day. And we will generally, this is a general statement on this, it may vary from practice to practice, as I, as a coordinating surveyor, would have the discussion with the accreditation contact person there in the first instance, but we are very flexible and structure ourselves around whatever fits into your practice. The first criteria is 50%, your practice must be operating at 50% of normal business on the day. You can't have a practice for accreditation on the day that does not operate. That's the first thing. The second thing, we generally, and we'll talk about the flow at present in a slide coming up. We need to have pre-organised interviews with the doctor, the principal doctor, or the doctor taking the interview. And that generally is about an hour for the interview, and depending upon the individual doctors, some will do medical notes with the doctor at the time, but otherwise it will be the doctor will then look at medical notes after the interview with the doctor. So generally interview the doctors first up. There's a requirement for, if you have a nurse, for the co-surveyor like myself to spend some time with the nurse, and we like a scheduled time to fit around that if we can. The doctor also, the accrediting doctor will need to spend some time with nurse also to look at equipment accordingly. I will then have some time, require about 20 minutes with the practice manager and about 10 minutes with a reception staff. So we need time with the doctor, we need time with a nurse if you've got it, we need time with the practice manager and time with the receptionist. And on discussion, at that initial discussion, we'll give you some timelines around that accordingly. Also, how to prepare is that have documentation and evidence ready and available accordingly. If you want to cut the time down, you make sure the document's there waiting, not for the surveyor to ask you for you to go and find it. Have it available, have it at a desk or on a consulting bed, all there for us, all laid out, however you want it, so it's direct accessibility accordingly. So you may be using documentation to support your evidence accordingly. Have it available. Don't keep it in your room up on the shelf, because then you've got to go backwards and forwards. I've got to keep asking for it. You've got to go and find it and bring it back. So have that evidence available accordingly, because that's quite critical. And where possible, In a logical order, because if you go start looking for stuff, bells ring for me. Are they prepared for the survey or not? And I'll change my surveying style. So make sure the evidence is available there. When we get to that evidence around documentation for CPD, etc., 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 what a lot of practices do, they may do it two ways. They may have a file there for Gary, and in Gary's file, he'll have his job description, he'll have a copy of his CPD, education and training, a copy of his CPR, and a copy of his immunisations. That's Gary, the practice manager. I go to Dr. A. In Dr. A, there will be a copy of his medical registration, a copy of his training certificate from the RACGP, a copy of the CPR certificate, and a copy of immunisation status. That's already in his or her file. So prepare files if you want. If you want to, like I do as well, I have an electronic file that sits on the screen, and everything is scanned and put into that file. So all the surveyors do in my practice is come on, there's a file there for Surveyor A and Surveyor B. Those documentations there, I click open Mary, and in Mary's file, there's a subfolder in there that's got documents in there, and I open that, and all the relevant documents for Mary are in that subfolder there. That's great. I sit there and go click, open, click, open, click, open, click, open. A bit of advice on this. Just do not provide the surveyor a copy of the 485 page policy and procedures manual as evidence accordingly. If you're going to evidence information out of your policy and procedures manual, please have that particular policy extracted and sitting under or either in a separate folder. Now, you need to understand that there is no requirement for standards for policy and procedures manual. There is a requirement for prescriptive evidence, but every other thing you can utilise a policy thereof. Make it as easy as you can for the surveyor on the day, rather than making it difficult if possible, because we then have to go looking, and that takes everyone's time up. And at the same time, makes us look further, because I say, is this practice ready or not? Now, a suggested agenda for an accreditation assessment on the day. This is orientation and entry. You need to understand, as I explained to you before, entering the practice, the surveyors will actually have identification of who they are, what they are, just aware the front desk that we are arriving at 9 o'clock or 10 o'clock or 2 o'clock in the afternoon, whatever it may be. So entering the practice, surveyors should enter together, and they'll have the respective badges on it. One thing that always raises bells with me when you introduce yourself on the front desk, they don't know who you are or why you are here. And that happens quite often. So staff need to be briefed in relation to the day accordingly. Now, the entry meeting, this is really, really important. We have that initial discussion with you, and then we may set the scene for the day in what we've agreed upon before, and how we're going to manage the day. And then, most critical part really is the guided tour of the practice. It's really important that you show us around the practice and your practice facilities, because at that point in time, we are actually still carrying out. We've started our assessment already, because we're looking, we're listening. I listen to the phones at the front desk while I'm waiting to see the practice manager. Are they asking the 3 identifiers on the phone to patients? Is there any signage up around that would substantiate any requirements accordingly? Is there a practice information sheet up? Is there things around? Are there policies put up? So visually, we look at things accordingly. Are there screenings? Is there security around, etc.? Where's the immunisation fridge? We'll talk about cold chain management walking around. We'll look at your fridge. Can you show us the documentation on temperature monitoring, etc., etc.? So we'll ask these questions as we move around, and then we've started our process. And we get a good indication from the guided tour of your practice. Do not underestimate the guided tour of the practice, because as a surveyor, we can tick off so many of the indicators as a result of that particular walk around from there. So some suggestions around the guidance entry meeting, which I've touched on already. The last point is that we would like, in this walk around at the end, the guidance is that we have a discussion around an exit meeting, and we give you sort of an indication after our walk around, after looking at what time an exit meeting may take place. It's important that an exit meeting takes place with anyone who is involved in the accreditation for the day. The exit meeting can be scheduled for a time, but it's important that they understand that. And all it is, it's only a 5 or 6 minute meeting just to say, hey, thank you very much, and provide you an overview of how any areas you may need to think about accordingly. Because surveyors cannot make a determination. We're only the eyes and the ears of what's called the decision makers accordingly. We can't say you have met. We might say you've met all the essential criterion accordingly, and then we'll move into where to from here, and we'll provide you some guidance. If you haven't met something, we'll tell you. You know, look, you've been short on some information here, and then we'll talk about the 14-day natural justice period, which takes place. You've got 14 days to provide the evidence that we suggest you provide after you get a letter from AGPAL. And if you provide that information in 14 days, you'll then be issued with an unqualified report. If you can't provide it within that 14 days, you'll be issued with a qualified report and an action plan. So we'll take you through the exit at that exit meeting, you know, where to from here. If you have the ability to be able to upload information in Accreditation Pro, upload it, because I will look at this before I get there. And the quality of those documents you upload will give me an idea of what I need to cover and not cover when I am there. So it gives me a good insight in relation to the process. Let's have a look now at the exit strategy. We do our report. We combine both reports on the day between the GP and surveyor and myself. This particular document then is sent generally by me in my case, because I'm normally accordingly, and then I then send that to our CLO, who does a quality check, and then that goes to you if there's a natural justice period, which I spoke about. You've got 14 days to raise some concerns and provide information. That then goes back to the CLO. The CLO then sends that to a decision maker who looks at the overall process and then issues an accreditation award. If you provide the information within 14 days, natural justice if you need to, but you may not need to, and we'll let you know on that particular day. Then, of course, the accreditation award is then provided from there. So in summary, there's some key points that you may need to think about. Business management systems is a new area accordingly. So you need to start to think about setting goals and improving services. As I said to you before, this is one which a lot of people struggle with as well, is around business management systems and what that requires accordingly. Now, some resources for you. Here is the two resources from the college, and they are available on the AGPAL hub. That is the patient guide feedback, and also they also have a resources guide as well, which is available. You can download that free of charge, and if you wanted, you can download the college standards free of charge, but they're available. Both these documents are available through the hub accordingly. Well, that brings us to the end of the presentation accordingly, and the end of the series on that we're going to present on the 5th edition standards accordingly. Does anyone want to make any statements or in the chat box before I sort of wind it all up accordingly? So does anyone want to come off mute and make some statements or comments on how you felt that the 3 presentations went over the 3 Wednesdays that that we did this accordingly. Meryl, thanks very much for your comments in the checkbooks. It has been a pleasure presenting to you, and I always keep saying to everyone accordingly, do not be afraid of accreditation. Do not be afraid that you're going to not get accredited first up, because you can be accredited maybe before you leave, because surveyors may say, have you got this information there and then? If not, you've got 14 days to provide information. And failing that, you actually have, you then have an action plan to move as well. So please don't stress about it. We all stress about it. Even I stress about it in my practice, because I want to be perfect right up front. I don't like failure. And I think a lot of practice managers are like that accordingly. So just think about it. Don't stress about it. We'll help you on the day of getting you across the line accordingly. So if there's no other comments, I wish you well. It's a pity I can't get up to FNQ and do your survey visits, which I'd like to do that. If it's a road show, what we do from sometimes is that we might organise a week where someone comes up and does a number of practices around if they all align accordingly. And I've done that up in Arnhem Land and New South Wales and Tasmania. If my diary is clear accordingly. Now, there is in the chat box, there is a survey visit which we would like you to complete. This provides feedback to AGPAL on the presentation, and also provides feedback to your PHN, so they can improve the education and training which may come from it as well. On the screen now, you'll see some resources that sort of support the college standards and also CQI accordingly. Janice, do you want to come off mute, and is there anything you want to say on behalf of the PHN before we?
Yeah, I'm Janine here, everyone. I just wanted to thank everybody for joining us for the first two series of the AGPAL hosted high performing primary care, and thank you, Gary, for a really informative presentation over the last few weeks.
Great.
Just to let you all know that we will be putting these webinars into a learning management system, and they will be accessible over the next week or so for use by other staff in your practices, and for the next 12 months they'll support you in going through the accreditation, as well as some of the other resources that Gary has provided. So we hope you've enjoyed the series to date, and really strongly encourage you to provide feedback, because that helps us inform future commissioning activities as well. So thanks again.
Thanks very much, Janice. And my final comment is the fact of, please speak, if you're an AGPAL client, please speak to your CLO, your client liaison officer. They're very skilled in the space of providing advice in relation to indicator determinations for you, and they'll help you through the process. So once again, thank you very much. It's been a pleasure being part of your education journey, and please complete the Survey Monkey, which is circulated accordingly. Have a great day, everyone. Bye.